The patient has been in the hospital for 11 days. Four specialists have evaluated her: a cardiologist, a pulmonologist, a rheumatologist, a neurologist. Nobody knows what's wrong. At 3 a.m., a nurse pages the resident on call. The resident calls you. You are internal medicine, the specialty every other doctor calls when the patient doesn't fit a single organ. The cardiologist's problem goes to cardiology. The gastroenterologist's problem goes to GI. The problem nobody can name, that one comes to you. You read the whole chart. You ask the question nobody thought to ask on day one. You'll get the answer tonight. 11 years from now, you'll be the one they call. Level 1. Medical student. You are 22 years old and you just got in. MCAT, 511. GPA, 3.79. 40% of applicants get in each year. You are one of the 40%. The loan paperwork arrives in June. You sign it without reading every line. The median graduating doctor leaves medical school carrying $212,000 in student debt. Loans only, not 4 years of deferred income. 17% owe more than $300,000 total. Undergraduate included? You won't think about any of this during orientation. You'll be holding a white coat for the first time. The first 2 years are mostly a room. Lectures, anatomy lab, physiology blocks, pharmacology, pathology. Memorizing the parts of a machine you have never touched. The human body has more name structures than you'll use in your entire career, and you learn all of them anyway. At the end of your second year comes step 1. Until 2022, it was a scored exam. A 240 meant one set of residency doors. A 210 meant another. Now it's pass-fail. The first-time pass rate for MD students is 91%. You pass. You won't know for 3 weeks. Those weeks you'll spend replaying every question you weren't sure about. In third year, medicine stops being a subject. The rotation cycle runs through internal medicine, surgery, obstetrics, psychiatry, pediatrics, neurology. Internal medicine comes in October. 6:30 a.m. The senior resident gives you one patient to follow, not two. 1. 4 hours, reading a single chart. The presentation takes another hour. On rounds, 3 questions answered wrong in front of the whole team. The attending corrects you without any particular anger. That somehow makes it worse. Every wrong question goes on the list. Sleep doesn't come easily that night. By November, something shifts. A murmur during a physical exam. You already know the answer before you check. A senior resident reads your assessment and plan and says it's actually pretty good. A patient asks you to explain their new diagnosis. You explain it. They understand you. You didn't have a word for this feeling before. You do now. Fourth year is interviews. The match is not competitive for internal medicine. More than 10,000 positions, more unfilled spots than any other field in medicine. On match day in March, the envelope opens. First choice. You are going to be a doctor. Internship starts in 8 weeks. Level 2. The intern. The pager goes off at 3:47 a.m. A nurse reports a potassium of 3.2. 19 hours awake, the chart comes up. The EKG loads. The patient is on digoxin. A low potassium on digoxin can be dangerous. You know this. Call the nurse back, order a replacement, document the exchange. Then back to the workroom, staring at the computer until the next page. This is intern year. The program pays you $70,000 to work 80 hours a week. That comes out to $8.75 an hour. The rules cap residents at 80 hours a week, no single shift over 24 hours. 43% of interns report working more than that. Pre-rounds are alone. 6 patients, every lab value, every overnight vital, every note the nurses wrote. You run through what the attending might ask. The question is never the one you rehearsed. Rounds begin at 9. Each patient gets a structured presentation: chief complaint, history, exam findings, assessment, plan, 6 times before lunch. Heavy afternoons bring 3 new admissions. Sign out is at 7 p.m. if nothing goes wrong. Something usually does. Studies of how interns actually spend their days found the same pattern everywhere. 40% on the computer, 18% with patients, 3% in education. You did not go to medical school to stare at a screen. You stare at the screen anyway. The first code is on a Tuesday. A patient admitted 2 days ago, a 67-year-old man with decompensated heart failure, goes unresponsive in the afternoon. The code team arrives. Someone hands you a stool and tells you to start compressions. Arms tired by the first 2-minute cycle. The attending takes over the resuscitation. You step back to the edge of the room and watch. They get him back. The code note gets written afterward, hands still unsteady at the end. Night float is worse. 8:30 p.m. to 7:30 a.m., covering 20 patients while the day team is home. 5 to 6 new admissions per night. The pages never stop completely. 2 or 3 in a row, then quiet, then a call from the ICU about a transfer. By 5 a.m., you've stopped noticing that you're tired. The senior residents tell you it gets better. You believe them, not because you've seen evidence, but because the alternative is too hard to sit with. Level 3. The resident. Now you're the senior on the team. 2 interns. They present to you. You present to the attending. 14 patients. 14 people in hospital beds, each with a name, a family, and a problem that needs a plan. The plan is yours overnight. In the second year, the diagnosis starts to feel like yours. Not because you're smarter than before, because you've seen enough cases to recognize the patterns without stopping to look them up. A sodium of 126 in a patient with cirrhosis is not the same problem as a sodium of 126 in someone 3 days out of surgery. Same lab value, different disease, different treatment, different outcome. Now you just know. That's what 2 years on the wards does. Teaching while still learning, and that gap is uncomfortable for a while. An intern asks a question. You give the right answer. You didn't know it a year ago, and you both know that. Mid-residency is the flattest stretch in training. Not brutal, not exciting, just service. The patients keep coming, the notes keep getting written, the new admissions arrive at 4 p.m. You're good at this now. That's part of the problem. Late in the second year, the question changes at every social event. It used to be, how is residency going? Now it's, what are you going to do? Internal medicine has 23 recognized subspecialties. For 2 years, you've watched all of them consult on your patients. The cardiologist arrives at 9 a.m. with a fellow and 2 medical students. The procedure takes 30 minutes, and he leaves. The gastroenterologist does the upper endoscopy and is gone before noon. The infectious disease doctor pulls a chair up to the bedside and stays for 45 minutes. These are not the same job. Some co-residents are heading straight into practice, no fellowship. The specialty invented the hospitalist model 30 years ago. Shift work, 7 days on and 7 days off, someone else takes over when the weekends. 2 of them signed their contracts in January. You watched. The fork is coming. Level 4. The fork. Internal medicine is the only specialty where finishing residency is the beginning of a second decision. The training is the same for everyone. The job afterward isn't. You have to choose. Fellowship means 2 to 3 more years on a stipend, $80,000, for a specialty that locks in your career identity. A cardiologist in private practice earns $650,000. A gastroenterologist who owns their own endoscopy center earns $900,000. Getting those fellowships is competitive. 2 to 3 residents for every available position. Infectious disease is a different calculation. You call the ID doctor when nobody else can figure out what's wrong. The fever has no source. The cultures keep coming back negative. The patient keeps getting worse. She'll sit at the bedside for 45 minutes and read the whole chart, every note, every lab, back to admission. She earns $260,000. Nephrology doesn't have enough applicants to fill its programs. That gap has widened every year. Skip fellowship and you start earning real money in July. The hospitalist path, 7 consecutive days on the inpatient floor, 14 to 18 patients, 12 hours a shift. Everything that happens to those patients from 7 a.m. to 7 p.m. is yours. Then home for 7 days. In residency, the weight of your patients followed you everywhere. The overnight beeper, the lingering worry about the sick one you signed out, the lab result you needed to recheck at 6 a.m. On the hospitalist schedule, the week ends and you walk away completely. The salary is $355,000. The outpatient path is the oldest version of the job. A panel of 1,500 to 2,000 patients, diabetes, hypertension, heart failure, managed across years of appointments. These patients have been yours for years. You know their families, their patterns, which ones catastrophize and which ones minimize. You know which ones are lying about the drinking. The salary is around $285,000. The inbox never empties. You make the call. Some version of you goes each direction. Level 5. The attending. Your name is on the note now. Not under the supervision of not resident. Just your name, your license number, and a billing code. Your liability. On the hospitalist schedule, 7 a.m. means sign out. 14 patients summarized in 7 minutes by the doctor who's been awake since 11 p.m. The overnight labs are already pulled on your phone during the drive-in. You know which ones matter before you reach the floor. Pre-rounds run room to room. Quick assessments, adjusting your mental picture of each patient before the formal team review. By noon, 3 discharges, 2 family meetings, 4 new admissions. By 7 p.m., you're signing out to the night team, driving home, finishing the last notes from the couch. 7 days later, the whole thing hands off. The hospital exists for someone else that week. Dinner at a reasonable hour, sleep. That is the trade. Not everyone makes peace with it, but most of the people who chose this path did so with clear eyes. The outpatient path looks different on Tuesday morning. 18 patients scheduled, 15 minutes each. The first one has 3 problems that need 25 minutes, behind by 9 a.m. and staying behind. The inbox had 42 messages when you arrived. 2 are clinically urgent. 1 is a prior authorization for a medication whose generic has existed for 6 years. It takes 20 minutes to complete. The panel is 1,500 people. Some of them have been yours for 8 years. You know the ones who minimize, the ones who catastrophize, the ones who are lying about the drinking. Notes finished at 8:30 p.m. Your partner asks how your day was. You say fine. Fellowship meant longer hours in training, and the procedure is what makes the job different. The first time you do it right, clean, no complications, the attending watching and saying nothing because there's nothing to say. You understand something in your body. You know why people spend 3 extra years for this. Afterward, back in the workroom, the inbox has 42 messages. Every path in internal medicine eventually produces the same private accounting. How much of the day was medicine and how much was everything else? Documentation, prior authorizations, inbox messages at 10 p.m., patient portal messages on Saturday morning. 49% of all American physicians report burnout. Internal medicine has sat near the top of that list for a decade. The diagnostic identity that drew most people here, the patient who doesn't fit a single organ, the question nobody thought to ask, gets whatever time the system leaves over. Some days that's most of the day, some days it's one patient in the afternoon, and they catch you off guard. Level 6. The veteran. At 45, you've seen enough to stop being surprised. The sodium of 114 that everyone is panicking about, you've seen lower. The presentation the residents call classic for pulmonary embolism doesn't look classic to you at all. You say so. You're right. This is what 10 years of internal medicine actually builds. Not speed, not confidence, but a calibrated sense of when to trust the patient over the numbers. A patient arrives who has been evaluated at 2 other hospitals in the past 6 months. A folder of records 2 inches thick. The previous diagnoses don't explain her symptoms. You read the whole chart. You ask the question nobody asked at either of the other hospitals. The answer changes the treatment. 6 months later, a letter arrives. It goes in the drawer. There are more than you can count in that drawer now. The administrative work has expanded year by year into whatever space the clinical work leaves open. A quality committee, a department meeting, 12 peer review charts, a resident evaluation that keeps getting pushed off. None of these take much time individually. Together, they occupy a third of your week. And unlike the clinical work, they don't give you anything back when they're done. The residents ask how you've lasted this long. You tell them about the patient with the 2-inch folder, about reading the whole chart when everyone else had stopped reading. You tell them the good days still carry the bad ones. They write this down. You wrote it down yourself once. You weren't sure it was true then either. Level 7. The Chief. The Department of Medicine is the largest department in the hospital. It contains every path internal medicine produces: the hospitalists who run the floors, the subspecialists who run the procedures, the outpatient generalists who know their panels by name, the researchers running trials that will change treatment guidelines in a decade. You run all of it now. Monday starts at 7 a.m. and ends at 6 p.m. without a single patient. Budget variance from last quarter. 2 division directors with competing claims on a new faculty line. A residency accreditation report due in 6 weeks. The hospital's chief operating officer wants to increase the hospitalist census from 16 patients to 20. You explain carefully that 16 is already the ceiling. The salary falls between $420,000 and $600,000, depending on the institution. You earned more as a practicing clinician. The difference is what the institution is buying, not clinical hours, but the ability to hold a department together, recruit well, and produce residents who match into good programs. This year, the program graduated 10 internal medicine residents. 3 matched into subspecialty fellowships, 3 took hospitalist positions, 2 went into primary care, 1 joined academic general medicine and will probably run a program like this one day. 1 left medicine entirely, took a job in healthcare consulting, which pays more than residency, less than attending, and doesn't require a pager. All 10 letters were written, everyone. The one who left came in before the final decision was made. She's one of the best residents trained in 15 years. She tells you the system doesn't give her enough time for the part she actually trained for, the 11-day mystery, the question nobody thought to ask, the whole chart. You don't argue. You've been managing that same tension your entire career. You write her the best letter you have ever written. She'll be fine. The new intern class arrives in July. The welcome address covers the usual ground, and then the part most people don't say out loud. Internal medicine is the specialty that asks the question no one else thought to ask. The training takes 11 years minimum. The debt is real. The inbox never closes. Most of them are nodding. They're not fully absorbing it yet. That's fine. Nobody absorbs it until they live it. One of them reminds you of yourself at 26. White coat already pressed, stethoscope already around her neck. She doesn't know yet about the potassium at 3:47 a.m. She doesn't know about the code note with unsteady hands, or the drawer full of letters, or the resident who left, or the day she'll understand all of it at once. She doesn't know the road is this long. She'll find out. They all do.